Dr. Tracy Verico, I'm so glad to have you back for part two of Coffee Chat with Dr. Tracy Verico. We are now on Dr. Verico's channel exclusively. Welcome back, or I guess I'm welcoming
Thank you.
myself to your channel.
Thank
Um,
you. Thank you. I'm so grateful for doing this with you today.
This is so awesome. So, for people who just know Dr. Verico and who don't know me, I am Kathy from Gossip, Rumor, and Innuendo. Every morning, I break down the latest, greatest in true crime in about 20 minutes, a whole day of court in just about 20 minutes. But I'm also a middle aged lady who's going through menopause and for whom Tracy Verico is my personal menopause doula. I would have burst into flames or stabbed somebody without her. And so we're doing Coffee Chat part two. Again, if you missed part one, you can find that. That video is now live and public on Gossip, Rumor, and Innuendo. But this is part two where we continue questions about menopause, perimenopause, and all of that jazz. So, a lot of the people from my channel had tons and tons of great questions for you, Dr. Verico. Let's talk about birth control and HRT. Can you be on the pill or birth control or whatever and still do HRT?
So, great question. You can be on some forms of birth control. There are different types of birth control. So, you can be on an intrauterine device at the same time as being on hormone replacement therapy. If you're taking a birth control pill in the form of an estrogen and progesterone combo pill, we really don't have any studies that say you can do that and HRT together. It depends on the patient. Sometimes I will allow it. Sometimes I will switch them to a progesterone only pill and then have them do HRT as well without the estrogen orally, again, because that estrogen risk increases the risk of clotting potentially as you're aging. So again, it depends. It's a conversation between you and your healthcare provider, but you can safely be on an IUD and hormone replacement therapy at the same time. There's nothing that says you can't.
I've heard people say, or a friend of mine's mom said, so it's like one of those, that instead of to ease her menopausal symptoms, she just stayed on the pill like long after her periods had stopped. She stayed on the pill to ease her menopausal symptoms. Is that a thing?
It is, yeah. So, I mean, you can safely, as long as you don't have other health reasons for why you have to get off the pill. So, for instance, if you have high blood pressure or if you have a clotting disorder, then we may say, look, it's not safe to take the oral estrogen component of your pill anymore. But it is true that you can safely stay on your birth control pill well into menopause. And remember, it's estrogen and progesterone. So it is giving you back some of the hormone that you are starting to lose with menopause. But the type of estrogen and progesterone in a birth control pill is different than the estrogen and progesterone we give you in the form of hormone replacement therapy. So sometimes I find that patients will get okay symptom relief with their birth control pill, but they'll get better relief with hormone replacement therapy. So it's again just a discussion between you and your provider about when is the time to transition over. As long as we don't see there's a pregnancy risk anymore, because I don't know about you, but I don't want to be pregnant at 50, or I didn't when I was 50. I tell them once your pregnancy risk is gone, there's no need for birth control anymore.
Oh, interesting. So, but you still could, I guess, theoretically get like randomly pregnant during perimenopause, or I guess not during menopause, but during perimenopause, there's still
Yeah.
pregnancy risk.
If you're still
Oh my
having
God.
a cycle, whether it's every 6 months or every 8 months, if you're having a menstrual cycle, you can get pregnant. It can be random. The other option is your partner could get a vasectomy. It's
For
an
sure.
in-office procedure and it's easier than getting a tubal ligation for women. So, that's another option. You don't have to take on all the burden of pregnancy prevention.
That's amazing. Yeah, he could go out there and snip, snip. In-office procedure. I somehow never knew it was an in-office procedure.
Yeah, it's a same day
Wow.
procedure and they recover very quickly as opposed to if we do a tubal ligation, that's an abdominal surgery that requires anesthesia and a little bit more recovery. So, again, we're always having these discussions with patients about like, what are all your options? I like to lay out all the options and say, here are the pros and cons of everything. What do you think's best for you?
Hmm. Wow. And what is the difference in risk by ethnicity? Like if you're as a Black lady versus a Hispanic lady or an Asian lady or a white lady, like what is the difference in the risk? And like, is there really a risk, or is that just somebody's like closeted racism coming out? I don't know.
Yeah, that's a really good question. So we actually do have good data showing there's big differences between ethnicities in women. First off, women of African American descent, Black women, if you want to call them that, or Hispanic women, they go through a much longer trajectory of symptoms than Caucasian and Asian patients do. So you can experience symptoms for 7 to 10 years. Caucasian patients, typically are average 4 to 10 years is the average length of time that you can go through symptoms.
Oh,
And Asian women seem to have the shortest timeline of symptoms. So there is great variation. And also, we know that the more severe your hormone symptoms are, or hormone deficiency symptoms and menopausal symptoms are, the higher your risk for heart disease, stroke, diabetes. And so for patients who have moderate to severe symptoms, we already know that African American women and Hispanic women have a much higher rate of heart attack and stroke than Caucasian and Asian women do, just ethnically. So if you also have really severe hormonal symptoms, that just adds another risk to your heart disease risk. So again, lowering those risks for you as you're aging is so critical. And acknowledging the ethnicity differences and addressing those with your healthcare provider is really important.
such a big deal and so interesting. Anytime I see anything broken out by like ethnicity, I'm like, okay, that's somebody in their crap. Like I have sort of routinely just, didn't think about it.
No, I mean, we have excellent data in the gynecology world, even in
Hmm.
pregnancy risks. African American women have a much higher risk of stillbirth, preeclampsia, pregnancy complications, maternal death from pregnancy. So there are big differences depending on your ethnicity in health risks and outcomes. And we're really actively trying to
Interesting.
work on addressing those things for, each ethnic population. We're not all the same. We're all different.
For sure. For
Mm.
sure. For sure. That's so interesting. And then let's talk about I know access to HRT. We spoke a lot in part one about HRT and getting access to HRT, but how does that vary? I mean, obviously, it's going to vary. Like, is there a doctor close to you? Is there a knowledgeable physician or nurse practitioner, whoever you're seeing? Is the person knowledgeable about all of these things related to HRT? But does access vary by insurance company or location in the country or anything like that?
So, unfortunately, because of the Women's Health Initiative study in 2002, after that study was released, we saw a huge drop off in education among healthcare practitioners. So, even as of this year, 2026, when you look at all of the OBGYN residency training programs in the United States, only 25% of OBGYN residency programs are teaching their residents about menopause treatment, education, and that sort of thing. I was of the training group that was in training before the WHI came out. So I was fortunate to get a lot of training in menopause care. But when you pull most doctors today, and I encounter this pretty often, they're all operating off of the false information that was disseminated about the WHI, and they never received any proper training in HRT. And so they're telling patients hormones are dangerous, it causes cancer, the estrogen's the cancer causer, so unfortunately, there's a lot
Wow.
of misinformation. And so I'm having to get on the phone with a lot of these providers and say, did you read the WHI study? Do you know the flaws in the data? Did you see the new guidelines? Go to the menopause .org society. Patients can go there and get great information. Go to the American College of Obstetrics and Gynecology site. They have great information about the safety profile and the benefits of hormone replacement therapy. So part of the problem we're dealing with is that study caused a whiplash of lack of education, not just in the general community, but the medical community. And now we're trying to make that time up and reteach what has been lost. So when you're looking for a provider, you want to ask the right questions. Did you get training in menopause and HRT? Yes or no? If a doctor's telling you HRT is dangerous, you need to unfortunately be prepared to say, I have studies that show differently, or have them show you the study they're quoting. And is it really dangerous? Because if you pull the guidelines today, it's a completely different narrative than it was in 2002.
Wow.
And so a lot of
That's
this is just
amazing.
it's just a lot of, misinformation that we're trying to unwind and re-educate our healthcare community. And unfortunately now patients have to be the educators. They have to be the advocates. And
Yeah.
so it's a two-pronged approach. That's why I'm teaching patients and I'm teaching healthcare providers.
And I think a lot of this starts with the patient, right? Because if like there was I don't remember what the vaccination was, but there was a vaccination that I wanted my son to get that at the time was only indicated for girls. And I remember saying to my pediatrician, well, I had heard that like boys can get this too. And I wasn't saying like, please give it to my kid. I was saying, can you help me understand why this is indicated for girls and not for boys, whatever it was. This was years ago. And he was just like, oh, let me, do a little research into that. And the next time we came in, he said that he had vaccinated his son. He had a son the same age as my son. He had vaccinated his child. And we had a whole conversation about it. He said he went back and did more research. And so while I think the tendency, at least for me historically, has been to say, like, that guy's the doctor, he knows, what do I know? And now
Yeah.
because patients are better educated.
Yeah, again, I mean, you assume that your doctor's telling you is truth. And again, not to disparage healthcare providers or doctors, but if they didn't get the training, they're going off what they're hearing. And sometimes it's just a conversation of like, I got on a call with a hematologist that told me, oh, this patient can't take estrogen. And I'm like, hold on a minute. She can, as long as it's topical, because it's not going to cause a clotting risk for her because she had a clotting risk. And he was like,
Mhm.
oh, no, no, no. And I'm like, hold on. I said, can you go and please read the current guidelines and then let's hop on a call. I'm happy to walk you through. And he's like, no, 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 just educate me. And I did. And at the end of the phone call, he was like, well, this is a totally different conversation. And I'm like, yeah. So again, the
Wow.
healthcare providers just have to be willing to learn something new. And, look, they're seeing 50 patients a day. They are burned out. They're exhausted. I don't know about you, but when I was in corporate medicine, I came home at the end of the day completely exhausted. I didn't have the bandwidth to want to learn something new or read a new study. And so that's part of the other problem right now is the education is not there, and we need to
Yeah.
change that. Education is key. So, that's kind of the background story. So again, when you're looking for a provider, did you get menopause training? Did you get training in HRT? If the answer is no, they're probably not the right doctor for you. If the answer is
Mm.
yes, maybe limited, okay, what are your thoughts about it? If they're sending you fear, it's probably not the right doctor. You always have options. And then again, I mentioned in the previous recording, if you're not a candidate for HRT or you don't feel you want to do HRT, we have other options. We have other medicines that will treat your symptoms and give you symptom relief and quality of life. There's no reason to suffer. And so again, that conversation, what are all my options, hormonal and non-hormonal? And if someone can't have that conversation with you, they're not well trained.
Mm. That's really, really important. Like feeling heard in the doctor's office. I know women particularly feel like, and I don't know if it's women talking to men or, women talking to other women. I don't know. But I have so many friends who have been like, I said I had X symptom. And the doctor said, yeah, 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 yeah. Just patted me on the head and sent me on my way. And that's not what I want in a provider at all. One of the things that I've really appreciated about our relationship is that you've taught me so much, just sort of conversations like this sitting in the office. It also wasn't like one of those quickie factory farm 10-minute appointments. You sat, you got to know me, to understand who I am, and have provided me so much education about this type of stuff. One of the things that I keep hearing come up is bioidentical hormones. I don't even know what that is. So can you explain a little more about bioidentical? Because I'm like, Susan Summers talked about that 20 years ago, but I still have no idea
Mhm.
what it is.
Yeah, so that's a great question I get from patients every single day. So, bioidentical means that the chemical structure of that hormone is identical to what you make. So, we're going to go a little deep here for a minute for those of you that may not be science geeks like me, but we're talking about organic chemistry, the structure of your hormone made up of carbon, hydrogen, oxygen, nitrogen. The structure is identical to yours. That's what bioidentical means. A lot of patients, and unfortunately, get rich quick marketing, who's all on the bandwagon for making money off of menopausal women, they're selling snake oil and saying if it's not compounded, it's not bioidentical. That's false. If you hear
Mm,
that, that's a red flag, because the pharmaceutical industry and all the products we're using for women for hormone replacement are bioidentical. But I mentioned earlier, birth control is a different type of estrogen and progesterone. They're different types. And we do have bioidentical equivalent options for hormone replacement therapy at your regular pharmacy. You don't need to spend a fortune. Now, where compounding pharmacies come into play is if patients have an allergy to, say, peanuts. At the regular pharmacy, progesterone, micronized progesterone capsules, which is one type of progesterone we use, is in peanut oil. So if you have a peanut allergy, I can't give you that, but then I compound it in a different oil. So compounding pharmacies are great if there's like an allergy to something in the medication, the base, what it's mixed in, or sometimes we'll use it if you're not at one dose, the pharmacy only offers these 2 doses, and you're somewhere in the middle, then the compounding pharmacy can customize a dose for you if needed. But the problem with hormone replacement therapy coming from compounded pharmacies is there's no regulation on what product you're getting from that pharmacy. So when they sampled multiple compounding pharmacies asking for the same drug, they found that every sample they got contained something different or didn't even contain what they asked for. So that's the problem with compounding pharmacies. They're not FDA regulated,
ah,
which means they have to have certain things that happen when they're producing. Do I use compounding pharmacies? I do. But again, it's not my necessarily go-to. I go to what's available that's been studied, that is regulated, and we know works. We have studies on it. And so again, if you're hearing bioidentical as an advertising ploy and they're saying you can only get it at a compounding pharmacy, I would run, because that is a red flag. They're just trying to make more money, and it is more expensive. I think the other question I get a lot is pellets. What about, I'm hearing people put pellets in their buttocks with hormone. Yes, that's a thing. Um,
like a suppository or like
it's
in the
it
skin?
it looks like a tic tac, and it gets surgically implanted in your buttocks, and it delivers hormones. So you can get testosterone, you can get estrogen. Now, again, this is not FDA approved. It has not been studied. It's very expensive. It costs about $600 to $700 every 3 to 4 months. And the downside is you have to go through a surgical procedure. You have to cut the buttocks open and insert the pellet. And once the pellet's in there, you're stuck with it until it wears off. So again, there are a lot of these things out there that have not been FDA approved. And it's, whenever there's a big population of people that are suffering. They're desperate to feel better. They'll do anything to feel better. That's when you start seeing these, get rich quick options start coming in, and there's a conflict of interest there.
That's wild. I had heard of pellets, but I was like, okay, whatever. I didn't realize that they like inserted it into, oh no. But everybody has to do what they have to do. Talk to me about hysterectomy and perimenopause. First of all, I can't figure out how you know if you're
Mhm.
like perimenopausal if you've had a hysterectomy. Doesn't a hysterectomy mean you're automatically like postmenopausal? How does all that work? And do you need HRT? Can you take HRT if you've had a hysterectomy? Like, how does all that stuff work together?
Great question. So, hysterectomy by definition means removal of your uterus. It doesn't necessarily mean removal of your ovaries. Your ovaries are what make your hormone, not your uterus. So, if you had a
Oh,
hysterectomy, you're no longer seeing menstrual bleeding anymore, correct? So, how do you know that you're menopausal if you're not bleeding, right?
right.
So that's where the blood work comes into play. That's where we sometimes will check a follicle stimulating hormone or FSH level to see if it's
Mhm.
in the menopausal range. But again, I come back to our previous video on your channel where I said, how do you know if you're a candidate for hormone? Are you having symptoms? So let's talk about the symptoms. Are you having them? And if you are, then yeah, you need hormone replacement. Can you do hormone replacement with a hysterectomy? Absolutely. Now, there are some patients that have their ovaries removed at the time of their
Right.
hysterectomy, and they're going into immediate surgical menopause, right? We're taking away their hormone production. Those patients benefit greatly from being put on hormone replacement therapy, especially if they're premenopausal and they're considered prematurely menopausal. That
Mm.
population of patients has a much, much higher risk of heart attack, stroke, blood clotting events, and aging and early morbidity and mortality if they're not treated with hormones. So, as I tell patients, as soon as your uterus is out, that doctor in the recovery room should be putting on HRT immediately for you. And so, if you had your uterus removed, you don't have to be on progesterone. So, what I explain is that estrogen makes the uterine lining grow, progesterone stabilizes it. If you're on estrogen alone and you have a uterus and you're not on progesterone, it can cause a risk for uterine cancer. So if you still have a uterus, you should be on both estrogen and progesterone. And topical progesterone is not enough to protect the uterus. I see this sometimes in these like hormone clinics. Patients will come in to me and they'll be on topical progesterone, and I tell them it's not protecting your uterus against uterine cancer. That is not the standard of care. So if you have a uterus, you should be on both. If you don't have a uterus, you don't have that risk for uterine cancer. So you don't have to be on progesterone. However, some patients need progesterone because they are having the mood swing, irritability, depression, anxiety symptoms, and sleep disruption. And that's where progesterone is helpful. So I have a hysterectomy and I'm on progesterone because I needed it for sleep and mood control. And so again, it just depends on your symptoms and whether or not you have a uterus or not. So great question.
Wow. Here's one that's probably a little bit unexpected from Tanika's 2 cents. Can you go through menopause while breastfeeding?
So you can have a lot of symptoms of menopause while you're breastfeeding. Because remember, you're coming off of, I don't know how soon this person is to delivering. I don't know if they're breastfeeding a year, but your hormone output is different when you're breastfeeding than when you're not breastfeeding. And so there is some hormone suppression that occurs when you're breastfeeding. And so you can have symptoms. Now, for those patients that are in their late 30s, early 40s having their babies. Remember in the other recording, I said you can start having symptoms as early as your mid 30s of low hormone. And so it is possible to go on hormone replacement therapy. The only issue is we can't give you estrogen while you're breastfeeding because that goes into the breast milk and to the baby. And we don't want to feed the baby estrogen. Progesterone is safe. That's why we use mini pills or progesterone only birth control pills when you're breastfeeding. It's safe for breastfeeding, safe for your baby. But we have to wait till you're done breastfeeding before we can initiate estrogen therapy.
Wow. Okay. And then I know that um Facebook can be very we're not on Facebook. YouTube can be very sensitive about certain words. And so I typically refer to our lady bits as my good pocketbook. So if I'm going through menopause, perimenopause, and my good pocketbook is all dried out, or itchy, or there are infections or whatever, what will help my good pocketbook?
Great question. So there's something called genitourinary syndrome of menopause, and most of us will be affected by it. It's due to the low estrogen state in your pocketbook. And so what can happen is you can start developing thinning of the skin, itching, burning, tightness, irritation, even without relations. And so it's easy to treat. We replace estrogen in the pocketbook. And within a few weeks, most patients see significant relief. We also have excellent studies that show as you age, do you always hear about the old ladies that are going into the hospital with urinary tract infections and they get it in their bloodstream, they get septic and they're
Yep.
disoriented? Well,
Yep.
we know that's due to low estrogen in the pocketbook. And so if we
Oh,
replace estrogen, we see a 50% reduction in urinary tract infections. So I will sometimes have women coming in that all of a sudden are getting all of these infections, whether it's bladder infections or pocketbook infections. And they'll be like, what is going on? I've never had this problem. I'm like, it's your estrogen dropping. We replace it, it gets better. So if you're struggling with repeated infections, that's probably the reason. And we can even see that in younger patients who are on combination birth control for more than 5 or 10 years. It suppresses your estrogen and testosterone level indirectly. And so they too can develop dryness and irritation and tendency to get infection. And again, we can treat them. It's a local acting estrogen. It doesn't treat the system, it's local.
I saw a short that you did where you said that sometimes people are on, I guess, like the topical, the estrogen patch, and then they need the gel or something like that. But there was an issue with insurance because that's not my personal situation. I saw it and I was like, oh, that's interesting to note, but I forgot about it. Can you explain like what the issue was with insurance related to getting estrogen in two different forms?
Yeah. So, unfortunately, again, your insurance company is not educated. And even the pharmacists sometimes are not educated in the hormone space. And so I frequently will prescribe a wide estrogen. So it treats the system. So maybe it's a
Hmm.
patch. And then if you're having dryness in the pocketbook, then I will order an additional local acting estrogen. And sometimes the insurance company will be like, oh, no, that's the same thing. And I'm like, no, it's not the same thing. And so they won't want to pay for the one version, they'll only want to pay for the other. And I have to have my staff get on the phone with the insurance company and say, you guys don't know what you're talking about. This is a separate therapy. It's safe to be on both at the same time. It's not adding to your level. You can't overdose on estrogen in this way. Or I have the pharmacist telling the patients the same thing. And I'm like, no, 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 no.
Oh man, that's crazy. This one I think is a very popular question. What about weight gain? I've gained so much weight in this past year. And I know we talked a little bit about that in the previous video with cortisol, which I'm like, belly fat. Oh my God. Because all I know is cortisol and belly fat because I'm on social media and I see the ads. But why the weight gain? What can you do about it? Help.
Yeah. So again, the weight gain is caused by low estrogen, which then causes insulin resistance. Insulin is the molecule responsible for using sugar in the body. So we become more insulin resistant, and that causes the body to lay down abdominal fat and what we call visceral fat, fat deposited in your organs, in your abdominal cavity, dangerous kind of fat. And so we see women gain, 5 pounds to, I don't know about you, but I gained 40 pounds. And I was like, I am
Me too.
feeling very uncomfortable in my body. So again, you're not going to estrogen your way out of weight loss. Estrogen isn't going to make you lose 40 pounds, but it is going to help the metabolic dysfunction and help the insulin work better. And of course, you have to do all the things. You have to exercise 3 times a week. You have to eat healthy, mostly protein and fiber. Stay away from boxed and bag items. They're all laden with sugar and simple carbohydrates, which converts to sugar. You want to make sure you're getting your sleep in, and proper sleep hygiene is 8 to 10 hours a night. Yes, 8 to 10 hours. That's a lot, right?
So much sleep. That's so much sleep.
Yeah. So
but I feel great when I do it, right? I feel like I got the Aura Ring specifically to monitor my sleep. It does a whole bunch of other things, but I was like, why do I not feel very rested? And when I look at the tracking on my Aura Ring, it's like, oh, because I was like awake and not awake and whatever during the night.
yeah, yeah. I mean, and then these little devices we have now, even the continuous glucose monitors, like if I see someone's becoming insulin resistant, I will have them wear one so we can see what foods are you eating. It's a visual explanation of what do you think you're eating that you think is good, but in fact really isn't for your
Yeah.
body, right? So we have all these great tools, which helps us get really great insight. And, again, there are some people that they will unwind some of that metabolic dysfunction with just estrogen, but there are some patients that benefit from adding a GLP-1 medication like Zepbound, Wegovy, semaglutide. Like these are brand and generic names, because we have studies that do show that synergistically your hormone replacement therapy and your GLP-1 work together to improve weight loss. We see better weight loss when women are on hormone replacement with their GLP-1 versus if they're on a GLP-1 alone. And so, yes, there are some benefits to being on a GLP-1 with your hormone replacement therapy.
You got to talk to your doctor,
You
because
have to
Dr.
have
Tracy
conversation.
Yeah, for sure. Because Dr. Tracy Verico is a doctor. She's not your doctor. You got to talk to your doctor. She's my personal physician, and I want to keep her all to myself. Look, I promised 30 minutes. This has been 30 minutes. It's been fantastic. Thank you, thank you, thank you. And I starred this comment because years ago, oh shoot, did I lose it? Years ago, my husband said to me, what are you doing today, or where are you going? And I was half asleep and I said, I'm going to see Dr. Verico. And he said, Dr. Miracle? And I said, yes, Dr. Miracle. And so in my house, we call you Dr. Miracle,
Aw.
mostly because you made me not hot and stabby, because I was real hot and real stabby. Um, I still keep the ceiling fan on, but I'm far less stabby. So thank you, Dr. Miracle.
Thank you.
I'm sure this video is in members only for my channel, but it's going to show up in the public feed for your channel at Dr. Tracy Verico, where people can find you, and all of the links, all the everything, the books. You should write a book. You should have a whole TV show. It should be Dr. Miracle all the time. Dr. Tracy Miracle, menopause doula to the stars. And by the stars, I mean me. Thank you, thank you, thank you so much for this.
Thank you, Kathy. I love your energy, and I love having you as a patient. It's just a pleasure. And I really enjoyed today. And thank you so much for having me on your show as well.
Thank you for coming. And I can tell you all the latest true crime while getting a pap smear. That's my superpower. I remember being in stirrups being like, oh my God, this whole thing with Alec Murdoch. It's a whole thing. Anyway, we're going to sign off, but you hold on for just a second.